It's like 6 a.m. So max we got till 6 to, I can tell you it's almost like it's up to 7:30. It's a max time, max time. So max I'll be finishing by 7:15 or 7:20, and I will allow last 5 or 10 minutes for doubts. And then uh, I'll not interrupt in between because I'll be keep because we have very less amount of time. We need to cover max information as much as possible, especially for NEET-PG. The topic which I'm going to discuss, these are very high yielding topics, very high yielding topics there on all previous year topics as well, previous year topics as well. These are the things you should go through. You should go through. So in between, I will not answer your doubts, ma, because if I keep on answering the doubts, we'll be derailing from the session. So I'll be keep on explaining the things in the last 10 minutes like that. Definitely, I'll answer all your 10 or 15, whatever it might be. No upper limit for the doubts. I'll keep on answering your doubts in last. If you have any doubts, please post now. I'll read it later, or if you post in the last after finishing the session also, that will be wonderful. So without wasting our time, I'll start our session. Before starting, very good morning, one and all. Appreciate your efforts getting up early and coming to this session. All those 100 students almost. We'll start with a very important topic: poisoning and their antidotes. All these things you might have known, just like a revision session for you. Acetaminophen, it is a paracetamol. So it is N-acetylcysteine. This table, very, very, very important table, ma. And aspirin or any tricyclic antidepressant, whatever it might be, NaHCO3, sodium bicarbonate, OP compound poisoning. Here we antidote is atropine, and then we all know pralidoxim is an adjuvant drug. It is not an antidote. It is an adjuvant drug. It is an adjuvant. Fantastic, ma, fantastic. Next, anticholinergic poisoning or atropine poisoning. I can tell you, atropine poisoning, physostigmine, physostigmine. It crosses blood-brain barrier. Important, it crosses blood-brain barrier, antagonize all central symptoms. Malignant hyperthermia, dantrolene, skeletal muscle relaxant. Next, benzodiazepine, flumazenil, alcohol, fomepizole. As I always tell, alcohol, it creates foam. It creates foam. Alcohol, it creates foam. So fomepizole. So don't get confused between these two. And the next, beta blockers, glucagon, glucagon. It might be calcium channel blockers also. Glucagon, methotrexate, folinic acid, or we can call it as leucovorin, or one more thing, citrovorum factor, anything is fine. All are same, all are same. And then now we have got a one more, what you call update with methotrexate, glucarpidase. This is also an antidote, alpha glucarpidase. This is also an antidote. If anyone asks you what do you mean by alpha glucarpidase, it is an antidote for methotrexate poisoning. It converts methotrexate to inactive metabolites and it get eliminated. Local anesthetic, typically he will tell bupivacaine because it is the most cardiotoxic one. Intralipid emulsions, intralipid emulsion. Next, opioids, naloxone, naloxone. And here comes a very important thing, ma. Heparin, protamine, dabigatran, idarucizumab, factor 10A inhibitors. This is oral factor 10 inhibitors. Andexanet alpha, andexanet alpha, warfarin, vitamin K1. Remember, it is K1. K1. Next, coming to iron overload, desferoxamine, doxorubicin-induced cardiotoxicity, joke scene. And this was the question which was asked recently in INACT also. Cyanide poisoning. Typical antidote is hydroxycobalamin. Also, we can use amyl nitrate, silver nitrate, sodium thiosulfate also. But typical antidote is hydroxycobalamin. Digoxin. We have digibind, we call it as digibind. It contains what fragments? Only FAB fragment. Only FAB fragment. No FC. No FC. Remember, it contains only FAB. Serotonin, cyproheptadine, and then methemoglobinemia. Again, it was asked a couple of times. IV, methylene, blue, valproate. Can anyone answer this one? Valproate induced hyperammonemia. Anyone? Valproate induced hyperammonemia. Okay, yeah, exactly, exactly. Fantastic, fantastic, fantastic. Not sodium bicarbonate, no. Carnitine, carnitine, carnitine. Valproate hyperammonemia. Again, this was the question. This was the question. Previous year question. This was hyper. This was like entire poisoning and antidote table. You no need to worry. I'll share the notes. Definitely, I'll share the notes. Just all the things will be in your main notes. These are just like additional points. No need to worry. I'll share it. And then here comes again a very, very important thing. Process of pinpoint pupil. Very important part. Pinpoint pupil. So you can remember the pinpoint pupil causes. We all know it is like typical OP poisoning. You can remember the cause of pinpoint pupil with again OP poisoning itself. O we have two, P we have two. O that is OP compound poisoning. OP compound poisoning, and one more P, opioid poisoning, and then P, phenol poisoning, and then pontine hemorrhage. And predominantly for you is OP compound poisoning, opioid poisoning. These two are very, very, very important. How to differentiate between those two? How to differentiate between those two? Opioid poisoning and then OP poisoning. Suppose if they give pinpoint pupil, pinpoint pupil, there will be some clues. There will be some pickup lines along with some liquid intake, or he might be mentioning former, former unknown liquid intake, or he might be mentioning former. In that scenario, it will be OP compound poisoning. In the second scenario, where he will tell he is drug addict. In that scenario, it will be opioid poisoning. So these are the clues here. Unknown liquid intake, former, go for OP poisoning. If you mention drug addict along with pinpoint pupil, then go for opioid poisoning. These are the main important things here. Cause of pinpoint pupil. And then here comes one more very important thing. Contraindications of morphine. Contraindications of morphine. Very, very, very important again. You can remember all the contraindications of morphine with the mnemonic Bihar. Bihar. Yeah. So contraindications of morphine. You can remember with the mnemonic Bihar. 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 B. Biliary colic, or I can tell you it is undiagnosed abdominal pain. Biliary colic, we all know it is going to cause a symptom of. Yes, mama, that is what morphine poisoning. That is what opioid. Opioid. That is what opioid. All opioids causes pinpoint. So biliary colic, undiagnosed abdomen pain, I can tell you, because that spasm of sphincter of footing leading to increased pain. In that scenario, if that is the scenario, what opioids which are safe? pentazocine, buprenorphine. These two we can consider it as safe in this scenario. Safe in this scenario. And then one more B, benign prostatic hyperplasia. And then IH, this is injury to head. Very, very, very important. Why? Why? Due to, because it is going to cause CO2 retention. It is going to cause CO2 retention, leading to vasodilatation, leading to intracranial tension. That's the number one. And number two reason will be morphine. It is the one which causes meiosis and as well as vomiting. These two interfere with the progression. These two interfere with the assessment of head injury. These two interfere with the assessment of the progression. And then A, here comes A important, age. Age, extremes of ages. Extremes of ages means pediatric and then geriatric patient, because they are more susceptible actually. So, and then here comes one more, respiratory insufficiency conditions. So respiratory insufficiency conditions means it might be COPD, it might be asthma, it might be emphysema, anything, whatever it might be. And here comes one more, a very important thing. We all know it is going to precipitate asthma. But in an asthma patient, if you want to use opioids, which opioids are safe in asthma? Fentanyl is safe. Fentanyl is safe. We can use opioid which can be safely used in asthma. Fentanyl because due to histamine release, less histamine release. This is what the main reason. It might be the expected question, which is safe. Biliary colic, undiagnosed abdomen pain, pentazocine, buprenorphine are safe. Here, asthma, fentanyl is safe. Fentanyl is safe. And here comes injury to head. What is the reason? CO2 retention, it causes nausea and vomiting, which is going to interfere with the assessment. A very, very important. This was the question which was asked previously. So that's all, ma. That's all about all the contraindications of morphine. Very important part is regarding to morphine. And then here comes one more, a very important thing, glaucoma. Every year, one question will be there from glaucoma. Every year, one question will be there from glaucoma. He won't ask in detail. He won't ask in detail. He will just ask which is going to increase the drainage, which is going to decrease the secretion, all such kind of things on few areas, nothing much, nothing much. So here, these prostaglandins are miotics, which I told here. These are the drugs which will increase drainage, increase the drainage. This rho kinase inhibitor also increases the drainage. These drugs, ABC drugs, these are going to decrease the secretion. You can remember the mnemonic ABCDs. ABCDs. A. Alpha agonist. B. Beta blocker. C. Carbonic anhydrase inhibitors. D. Decreased yes secretion. All ABCDs. So decrease the secretion. Decrease the secretion. Remaining all increase the drainage. Increase the drainage. Increase the drainage. Yes, yes. Prostaglandin. This is what prostaglandin analogs from prostaglandin F alpha analogs. So all the drugs ending with a prost, they are prostaglandin analogs. As you already know, they are going to increase the drainage. Which drainage? Uveoscleral outflow greater than trabecular outflow. Uveoscleral outflow greater than trabecular outflow. So this is what the characteristic point. And is there any other additional points? Yes, these are the first line drugs usually in the treatment of open angle glaucoma. Open angle glaucoma. Specific areas related to this part, prostaglandin. Iris pigmentation. Iris pigmentation. This was the question which was asked. Iris pigmentation, and then increases eyelash thickening. And then in aphakic patient, it may leads to macular edema. All these anti-glaucoma drugs, you please, when you are reading pharmacology part, please correlate with ophthalmology. Correlate it and then read it. And then coming to myotics. Myotics, as I told you, increase the drainage. So the option which is present here is pilocarpine. So this mechanism of action has already, it is going to increase the trabecular outflow. OF means outflow, ma. OF means outflow. OF means outflow. Here both Uveoscleral, trabecular, here only trabecular outflow. Is there any additional point related to this part? Yes, we don't use this one regularly. It is considered as a last option, pilocarpine. It is considered as last option. Why? Because of all the potential areas like headache, broic, which are very potential areas. That's why we consider it as a last option. Next, coming to alpha agonist, and this was a question which was asked recently. Alpha agonist, we have dipivefrin, is a prodrug converts to epinephrine, and apraclonidine and brimonidine. These are the drugs which we have. Next, coming to mechanism of action, as I told you, they are going to decrease the secretion. That will be the main part. That will be the main part. So now, what are the additional mechanism of actions here? So decrease the secretion, it will be there. Decrease the secretion, it will be there. Along with increases trabecular outflow, increases uveoscleral outflow, it is for dipivefrin. So it has all the actions, but predominantly decrease secretion. Along with that, it can increase trabecular outflow, it can increase uveoscleral outflow. But this apraclonidine and then brimonidine, as I told you, they are going to decrease the secretion, but they increase the uveoscleral outflow also. Uveoscleral outflow, only uveoscleral outflow. Here it both. Next, what are all the points here? Nothing much. Apraclonidine, even apraclonidine, it is useful for short term to control hikes in intraocular tension after surgery. After surgery, it is used for the short term apraclonidine. Brimonidine, we can use it for long term. Short term plus long term we can use. Short term plus long term we can use. Which one use it for short term? Apraclonidine, it is used for short term. Next, here comes a very important thing regarding ADRs, ocular allergies. Which has more? Apraclonidine greater than brimonidine. And here comes a very potential ADR which was asked recently. Sir, slide not clear. Oh, okay. What about now, ma? Rohita? Is it okay now? Yes. Okay. So ocular allergies. And here comes a very important thing. Brimonidine B. It crosses. That means to say it bypass blood-brain barrier. Brimonidine bypass blood-brain barrier. That is, it crosses the blood-brain barrier, leading to CNS depression. The black pigmentation is dipivefrin. No? The black pigmentation is dipivefrin. It causes CNS depression. So that means it should be contraindicated in less than 2 years. This was a question which was asked. Which glaucoma drug, alpha agonist, which was contraindicated in children? Brimonidine. Dipivefrin, it is going to cause black pigmentation. That's good. That's all about this part. Alpha agonist and beta blockers. We have timolol and betaxolol. As you all know, these are going to decrease the secretion. Nothing much. As I told you, ABCDs. Now, coming to efficacy, which has higher efficacy, timolol greater than betaxolol. As you know, timolol is a non-selective, betaxolol is a beta 1 selective, which has less pulmonary cardiac ADRs. Betaxolol. This is what a very important thing. Protective effect on retinal neurons. It is done by betaxolol. Next. Is there any characteristic ADR? Nothing much. Dryness, stinging sensation. Stinging sensation. That's it. Nothing much. Here comes carbonic anhydrase inhibitors, acetazolamide, brinzolamide, dorzolamide. As you all know, They are going to decrease the secretion. Nothing much here. Mechanism of action. So these are the drugs which are used in angle closure glaucoma. These are one of the first line drugs along with mannitol used in the angle closure glaucoma. Regarding ADR, nothing much. It may lead some bitter taste, non-specific ADRs. Nothing much. Nothing much. A carbonic anhydrase inhibitor. Here comes a very important part: Rho kinase inhibitors. Rho kinase inhibitors. These are the drugs ending with a Sudil. 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 Nitarsudil. Ripasudil. As you all know, this is going to increase the trabecular outflow. I told you they are going to increase the drainage. What drainage? Trabecular outflow. Trabecular outflow. Next, here what are the characteristic, very important characteristic areas of rho kinase inhibitor? It is going to do something with the conjunctiva. It is going to do something with the cornea. So what it is doing with the conjunctiva? Conjunctival hyperemia. One. And what it is doing with the cornea? Cornea verticillata. That is golden brown pigmentation. Golden brown pigmentation. That's all. That's all about all the drugs in the glaucoma. That's all about all the drugs. All the points I have covered in glaucoma. Please correlate with the ophthal part. Please correlate with the ophthal so that you can have a clear cut vision. Clear cut vision. No need to worry, ma. I'll provide the notes so that you can add, if any additional points are there, you can add there. You can add to your notes. Next, here comes every year one question will be there from gout. Every year one question will be there from gout. Acute gout, chronic gout. Mostly he will be giving the drug name. Like he will be asking which of the following used in acute or which of the following used in chronic. Next we have NSAIDs. These are the first line drugs. These are the first line drugs, very important. And then we have one more thing used in acute called colchicine. This colchicine is an anti-mitotic drug. Anti-mitotic drug. Okay, sir. What is this colchicine now? It is a second line drug. Second line drug. Why it is not a first line drug? It is second line drug due to potential ADRs. ADRs. Okay, sir. What is there any advantage with the colchicine? Yes, definitely. It is a fast acting one. It is a fast acting drug. If anyone asks you, acute gout, fast acting drug, go for colchicine. Acute gout used to treat early gout flares. Early gout flares. Go for colchicine. Go for colchicine. Next, coming to chronic gout. Coming to chronic gout. These are the drugs we have. Allopurinol. What this allopurinol is doing, as you all know, this is going to inhibit xanthin oxidase, which is an enzyme involved in the production of uric acid. Next, okay, sir, xanthin oxidase is given. Okay, but what is there any additional points with this xanthin oxidase? Yes, this is a first line drug. First line drug among uricosuric agents. That is in the chronic treatment or in the uricosuric agent. This is the first line drug. That is first line in the chronic therapy. First line in the chronic therapy. So can we use it for secondary hyperuricemia or hyperuricemia in malignancy? Yes. Used in hyperuricemia in malignancy. Yes, we can use. Yes, we can use. We can use this one. We can use this one. Next, coming to probenecid. Probenecid, what it is doing? This one, it is inhibiting the synthesis, allopurinol, but this probenecid, it is inhibiting the reabsorption of uric acid by inhibiting urate 1 transporter. By inhibiting urate 1 transporter. This you already know. This you already know. Yes, 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 yes. It is a competitive inhibitor. Yes. It is a reversible competitive inhibitor. It is a reversible one. So that's all about probenecid, nothing much. It is a second line drug. It is a second line drug. It is a second line drug. Next, coming to febuxostat. The name itself is saying XO, XO. XO is nothing but xanthin oxidase. XO is nothing but xanthin oxidase. Stat, that means stopping. Stat, that means we are stopping that one xanthin oxidase. So, what you call it is going to inhibit xanthin oxidase. Okay, sir. Allopurinol is doing this one. This one is febuxostat is also doing that one. Nothing much. Nothing much. We can use febuxostat also, but one characteristic difference. It cannot be used in hyperuricemia in malignancy. Remember this one. Which one we cannot use? Febuxostat, because nothing much. Febuxostat cannot be used in hyperuricemia and malignancy. Allopurinol can be used. And then here comes one more drug, pegloticase. These are uricase analogs, pegloticase and rasburicase, two things. So where we use this pegloticase? This was a question which was asked. This is also the question which was asked. This is also the question which was asked. All these are previous year questions only. Every year he will ask something. Pegloticase, it is used in severe refractory chronic gout. In the last scenarios, we will use this pegloticase. Next, coming to rasburicase, where we use this one? This is used in hyperuricemia in malignancies. Remember, rasburicase, it is used in hyperuricemia in malignancies. Pegloticase, it is used in refractory chronic gout. Refractory chronic gout. Very important, all these points are very important, all these points. So that's all about all the drugs used in gout and their characteristic relevant points related to gout. Now, here comes a very important topic for a NEET-PG. Two important things in CVS chapter. One is digoxin and the other one is amiodarone. We'll discuss it. So, digoxin. So here you can see the mechanism of action of digoxin. Mechanism of action in your exam. If they give anything like this, uh, one is sodium, potassium, ATPase. Another one is calcium exchange, sodium calcium exchanger. If they give two things in your exam, if they focus something which is inhibiting sodium, potassium, ATPase, then he's talking something about. Sir, again, slide not clear. Is it not for now? It is not clear, ma. Giri, for everyone, is it like that or no? In your question, if they give something like which is showing sodium, potassium, ATPase and sodium calcium exchanger, and he's focusing something towards sodium, potassium, ATPase, then blindly go for digoxin. Blindly go for digoxin part. So, what is the mechanism of action of digoxin? So, it is going to inhibit sodium, potassium, ATPase. Okay, sir, where it is going to bind? It is going to bind at a potassium site. Very important question. This was potassium site. This is how it is going to act, and consequent things happen, which is going to increase the calcium level, leading to increased contraction. This is how digoxin is going to act. Now, what are the indications, sir? Where we use this digoxin? Number one, we use this one in heart failure. What type of heart failure, sir? Systolic heart failure with a reduced ejection fraction. And then we use it in atrial flutter and as well as atrial fibrillation also. These are the two main indications. Nothing much in detail about this indication. Here comes our ADRs. This is where examiner tries to confuse you. Coming to ADRs, non-specific like extra cardiac ADRs. Obviously, we know yellow vision. We call it as xanthopsia. And then the second one, gynecomastia. Of course, it is a rare area. Predominantly, most common ADRs are GIT related ADRs. Diarrhea, abdominal cramps, most common are GIT related ADRs. And then coming to cardiac ADRs, almost all type of arrhythmias are seen, nothing much there. But toxicity, this is where examiner tries to confuse you. Toxicity. What are the conditions where digoxin toxicity is increased? Very important, ma. Hypokalemia, decreased potassium, increased calcium, decreased magnesium. These are the conditions where digoxin toxicity increases. Very important. Digoxin toxicity increases by hypokalemia, hypercalcemia, and hypomagnesemia. Because as already I told you here, it is going to bind at a potassium site. If there is no potassium in our, if there is less potassium in our body, more Digoxin go and bind there, more is the action is showing. So that's how. When there is less amount of potassium in our body, it is going to bind more. When obviously digoxin is going to increase the calcium levels. If there is hypercalcemia, still more what you call toxicity. And calcium magnesium both are opposite. Calcium magnesium both are opposite. These are the electrolyte abnormalities where digoxin toxicity is increased. As we already know, this toxicity is managed by, as already I tell you, DG bind, DG bind, DG bind. That's all about digoxin, Patma. Nothing much, nothing much. Yeah, that's all. Nothing much related to digoxin. I just want to concentrate this part. This part, this was the question, and mechanism of action. This was the question. This was the question. He may ask what you call picture representation also, focusing those two things. Next, coming to amiodarone, examiner's favorite topic, amiodarone. So, what is this one, ma? What syndrome it is? What syndrome it is? What syndrome? Blue man, fantastic, fantastic. Blue man syndrome. Photosensitivity reaction. Any picture showing blue color pigmentation on the face, blue color pigmentation on the face, blindly go for blue man syndrome. Blue man syndrome. That is amiodarone. Blue man syndrome. It is also known as Smurf skin. It is also known as Smurf skin. Smurf skin. Okay, sir. What are all the pulmonary fibers? That is also one more idea, ma. One more idea. So, what are all the points with the amiodarone? Mostly, we'll be asking what you call ADRs. But let's talk what are the important points with the amiodarone. Amiodarone is the one which is belong to class 3 antiarrhythmics, but it have all the properties of arrhythmics. That means it has 1, 2, and 4 as well, but predominantly belong to class 3, but it has all the properties. Also, it is a broad spectrum antiarrhythmic drug. Okay, where we use this one? Ventricular tachycardia, ventricular fibrillations, mostly. Okay. So it's the most commonly used antiarrhythmic drug. As this is the most commonly used antiarrhythmic drug, that means to say amiodarone will try to tell to all the other antiarrhythmic drugs, like I have more clients. I have more clients because it is the most commonly used antiarrhythmic drug. So it will tell to all the antiarrhythmic agents, like I'm having more clients than you people because it is a top class one. So now clients, we will elaborate the clients now. CLIENTES. We will elaborate all the points in the clients now. See, corneal microdeposits, corneal micro deposits. Number one, ADR. Number two, lung fibrosis, that is pulmonary fibrosis. This was asked almost 4 or 5 times. Lung, both in INICT and NEET-PG. Lung fibrosis, pulmonary fibrosis. And then, here comes, he may go to bit extent, lung fibrosis. If we give dose less than 200 milligram per day, lung fibrosis is less common, less common, less common. Remember this. Doses you need not remember, but he may go bit in detail if he wants. Less than 200 milligram per day. Next, coming to LI again, LI, liver toxicity, liver toxicity. E is nothing but elongation. What elongation? QT interval, elongation of QT interval. And then N, neuropathy, neuropathy. What neuropathy? Peripheral neuropathy. Remember, again, this is also one more repeated one. Peripheral neuropathy. Peripheral neuropathy. So all those proximal muscle weakness will be there. Shoulder, hip, all those proximal muscle weakness will be there. Next, thyroid abnormality. What thyroid abnormality, sir? Both hyperthyroidism will be there. Hypothyroidism also will be there. Hypothyroidism also will be there. Why it is having hyperthyroidism, sir? The name itself, iodine, amiodarone, iodine. It is an iodine containing drug. So hyperthyroidism because it is an iodine containing drug. Why it causes hypothyroidism? So inhibits the peripheral conversion. Inhibits the peripheral conversion. inhibits peripheral conversion. Next, yes, smurf skin, also known as blue man syndrome or blue pigmentation. Blue pigmentation. So these are all the points with the amiodarone. These are all the points with the amiodarone. Very, very, very important. This is a like 5-star topic. This is amiodarone is a 5-star topic. So, Ani, as we discussed the pulmonary fibrosis, let's discuss what are all the drugs causing pulmonary fibrosis. Let me put that one. What are all the drugs causing pulmonary fibrosis? Drugs causing pulmonary fibrosis. I think in VSV session, I think so I had told a mnemonic for drugs causing pulmonary fibrosis, a very important one. New MacBook. New MacBook. Yes, yes, fantastic, Harina, Harina, fantastic. So new N nitrofurantoin, nitrofurantoin, new M methotrexate, mitomycin, 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 A amiodarone, amiodarone, C carmustine, carmustine, chlorambucil, chlorambucil, B busulfan, and then bleomycin, bleomycin, Wo oxaliplatin, oxaliplatin. These are all the drugs causing pulmonary fibrosis. Very important. New MacBook. New MacBook. Very important. Drugs causing pulmonary fibrosis. This is also a previous year question. This is also a previous year question. This is next. Again, these three drugs are previous year questions. My anti-anginal drugs, all the three are previous year questions only. He didn't ask nothing much, just mechanism of action, nothing much, just only the mechanism of action he asked. So let's talk about important points with each and every drug. All the three are previous year questions. Ivabradine, the name itself, first one, I. So it is going to inhibits funny currents by blocking hyperpolarization activated cyclic nucleotide channel, nothing much, by blocking HCN channel. Remember that HCN channel. It is going to inhibit the funny current. Fantastic funny current. Next. VA. So this is I. This is VA. It is causing vision abnormalities. Okay, sir. What is this vision abnormalities? It is going to cause pains. Intense bright light. Cause pains. ADR. Characteristic ADR of evaporating. Next. Brady. That means to say it is going to produce bradycardia. Bradycardia. It is a pure bradycardiac agent. Pure bradycardiac agent. Okay, sir. Beta blockers also decrease the heart rate. Then what is the difference between ivabradine and beta blocker? The only difference is it is going to produce bradycardia without affecting contraction. But beta blockers, they decrease the contraction. So this is what important point without affecting the content. That is what we call pure bradycardiac agent. Pure bradycardiac agent. Okay, sir. Where we use this one? Where we use this ivabradine? Heart failure greater than angina. We can use in both situations, both situations. But if they give both heart failure and as well as stable angina in your option, go for heart failure first because it is the only FDA approved indication. This is European medical agency indication. This is for both. So if they give both, go for heart failure first. Go for heart failure first. He will not give both, but if you give both, go for heart failure only. Go for heart failure only. That's all about ivabradine. That's all about ivabradine. Next, coming to nicorandil. Again, I discussed in detail about nicorandil in the VSV session, I think so. NI. It is nitric oxide donor. CO. This is channel opener. So Nico. What channel opener, sir? ATP sensitive potassium channel opener. ATP sensitive potassium channel opener. If it is nitric oxide donor, it lead to venodilation. Potassium channel opener, potassium hyperpolarization, arteriolar dilatation. If there is venodilation, it leads to decreased preload. When there is arteriolar dilatation, it leads to decreased afterload and as well as coronary artery dilatation. Okay, sir, everything is okay. Crystal clear. It is a nitric oxide donor, potassium channel opener. Where we use this one? Where we use this one? Nicor, if you see anyone a drug name Nicorandil in your exam, so it is a drug ending with a dil. Dil means Hindi. It means heart. So it has something effect on the heart. What that something effect? R refractory angina, refractory angina. Refractory angina. So all the points with the nicorandil, all the points with the nicorandil. So it is used for refractory angina. Next, coming to ranolazine, nothing much with ranolazine. The only point you need to remember is it is going to inhibit late inward sodium channels. In the ischemic conditions, late inward sodium channels aggravate leading to arrhythmia. So it is going to inhibit the late inward sodium channels. This was the main mechanism, but he may ask something also. It is going to inhibit fatty acid oxidation. He may ask you this part. Fatty acid oxidation is inhibited by. So predominant action is this one. Predominant. This was a question. Late inward so ranolazine mechanism of action. He just asked like this. Late inward sodium channel. He gave late inward potassium channel, calcium channel, sodium channel, something like that. Late inward sodium channel. It is going to do something with a sodium channel. Something with a sodium channel. So ranolazine. So R is nothing but ranolazine. Na is nothing but sodium. Na, that is nothing but sodium. What sodium? Late. Late inward sodium channel. Late sodium channels, right? So that's all about ranolazine. So late sodium channels. Don't forget this one. Late sodium channels. That's all about these three, nothing much. That's all about these three. And here comes very important. Every year, one question will be there from extrapyramidal symptoms. Every year, one question will be there. Let's discuss now. So, what are all the extrapyramidal symptoms which are associated with antipsychotic agents? So, we have acute muscular dystonia. High risk is young age. High risk is young age. Young age. What are all the features will be there? It is very early to appear. It is early to appear. Okay. Acute dystonia means abnormal spasms. Spasms of what? Muscles. What muscles? Spasm of face muscle, tongue, neck, back. All these things will be there. Oculogyric crisis. Oculogyric crisis. All these things will be there. What is the treatment part, sir? Benzotropine. 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 If not, first option will be benzotropine only. If not, diphenhydramine we can give. If these two are not in the options, then go for benzohexol. Benzohexol or trihexyphenidyl. Both are same. Trihexyphenidyl. We are not using this for benzohexol because of abuse potential. Benzohexol, trihexyphenidyl, C-hex. This has abuse potential. That is the reason why we are not using that commonly now. But in exam, if they give that, if they don't give benzotropine diphenhydramine, then go for benzohexol. Otherwise, 99.99% he'll be giving benzotropine only. Next, coming to akathisia. In akathisia, what is the problem here? Restlessness without anxiety, just like how you will be sitting in front of, like outside of your Viva room during your UG days, how will you be feeling? Restlessness with anxiety there, but here without anxiety, right? You will be moving here and there, here and there, here and there. That is what the thing. How do you treat akathisia, sir? Propranolol. Propranolol is the most effective drug. Most effective drug. If it is not in the options, then go for clonazepam. If we ask you what antidepressant is used there, mirtazapine. Mirtazapine. It is antidepressant. It is an antidepressant. These are the last scenarios, but predominantly we go for propranolol. Next, coming to Parkinsonism, all the features are there. High risk is elderly. See, Parkinsonism and tardive dyskinesia, high risk is elderly. High risk is elderly. All the features of Parkinsonism, nothing much. What drug we use, sir? Benzotropine. Benzotropine. Or we can use amantadine. 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 That's all. Next, tardive dyskinesia. What is the reason for this tardive dyskinesia? The reason for tardive dyskinesia, it is due to upregulation of super sensitive D2 receptors. Upregulation of super sensitive D2 receptors is a reason for tardive dyskinesia. Remember, it is late to appear. Early to appear is acute muscular dystonia. Late to appear is tardive dyskinesia. So, what will be the repeated involuntary movements like a tics? Repetitive, repetitive involuntary movements. Repetitive involuntary movements will be there. Okay, sir, what is the treatment for this tardive dyskinesia? First, discontinue the offending agent, discontinue the drug, discontinue the antipsychotic agent. What drugs are benefited here? VMAT2 inhibitors, vesicular monoamine transport 2 inhibitors. What are those? What are those? Valbenazine, tetrabenazine. Sorry, deutetrabenazine. Valbenazine and then deutetrabenazine. These are most effective. These are most effective, most effective, most effective. Next, rabbit syndrome. Rabbit syndrome. You all know rabbit. It has mouth. It has continuously. It will be having that grinding thing. So perioral tremors. Perioral tremors. Benzotropine. Benzotropine. Mostly, he will be asking you treatment part only. Treatment part only. He will give some scenario and will ask you for a treatment part. This is how he's going to play the game. Extrapyramidal symptoms, again a five-star topic, very important. Extrapyramidal symptoms part. Now, let's talk one more thing in antipsychotic agents, clozapine. Very, very, very important, clozapine. As you all know, clozapine, close, the first four letters, it is close. So, with whom we can do scam? When people are very close to us, when they are very close to our heart, we can easily cheat them. That was the thing which generally happens in relationships. People with whom we are very close, it's easy to do scam them. It's very easy to do scam. So people who are very close to us, we can scam them very easily, but don't do that. Don't do that. So now, what are all the points with a close-up point? Very important, scam. So I'll tell all the points with the scam itself. See, saloria. Siloria is nothing but increased salivation, that is increased saliva. It is also known as wet pillow syndrome. Wet pillow. It is due to central action. What is the treatment, sir? Glycopyrrolate. Because there is a very potent anti-secretory agent treatment with the glycopyrrolate. Okay, sir. 1 year finished. Second year sedation. Sedation. This was also a previous year question. Previous year question. At second generation antipsychotic agent causing more sedation. And one more SSR, seizures. Seizures. This is also a previous year question. Seizures. How you will treat close-up and induced seizures? Treatment with a valproate. treatment with a valproate. So these are the yes things here. Yes. Next, coming to C. C. C means constipation. Again, this is also previous year question. Previous year, I didn't remember the exact year actually. Constipation. He gave the question like we were starting, we were using one antipsychotic agent, and for some reason we switched it from one antipsychotic agent A to B. After switching it to B, the patient developed a constipation. The most likely the agent is close up, and this is what the question. Okay, he gave that question, but he may ask you the treatment now if you want to ask, if he wants to ask. So what is the treatment part? We can use stool softeners or secretagogues. We can use stool softeners or secretagogues. Which laxative is contraindicated in close-up? And can anyone tell? Contraindicated. Laxative contraindicated. Laxative contraindicated here. Anyone? Laxative. Generally, we use laxatives. Laxative contraindicated in clozapine induced constipation. Fine. Psyllium husk. Psyllium husk. Generally, this is a laxative. But this is contraindicated in psyllium in close-up and induced constipation because the psyllium has it increases the colon transit time. Increase the colon time already in constipation. Here, obviously, the colon transit time is increased. This psyllium has it is going to absorb all the water. It is going to increase the colon transit time. Still leads to aggravation. So, laxative contraindicated in close-up and induced constipation is psyllium husk. That's all about a C, SCA. As you all know, agranulocytosis agranulocytosis. So blood checkup is recommended for every 2 to 3 weeks for the first 6 months. First 6 months. Now he may ask you absolute neutrophil count less than 500 per millimeter cube. If this is a scenario, then we need to stop the drug. Or you can treat it as like agranulocytosis. And if you want to treat granulocyte colony stimulating factors, we need to give M. SCAM, M, M, myocarditis, myocarditis. And there is one more thing. This especially this myocarditis occurs only in first 6 weeks of the treatment. Occurs in only the first 6 weeks. Then we have one more ADR, metabolic syndrome. Metabolic syndrome, increased weight, hyperglycemia, hypertriglyceridemia, all those things will be there. Metabolic syndrome. And then there is something with a M, dilated cardiomyopathy. Myopathy, that is like dilated cardiomyopathy. It is not skeletal muscle, cardiomyopathy. Okay, sir, up to here, this is okay. This metabolic syndrome, what are the other drugs causing highest risk of having metabolic syndrome? Again, this was one more year question. This was metabolic syndrome, clozapine, olanzapine. These two we all know, but there is something quetiapine. Quetiapine, high dose of quetiapine is these three having the high risk of metabolic syndrome. High risk of metabolic syndrome. So we have discussed all the points with clozapine now. Fantastic. Is there any additional point with olanzapine? Yes, definitely yes. It has highest placental crossage. Highest placenta cross. Antipsychotic agent with the highest degree of placenta cross is olanzapine. Olanzapine. Next, quetiapine. The antipsychotic agent which is associated with the cataract, this quetiapine. This is associated with cataract. This is associated with cataract. Okay, sir, clozapine. You have told everything about clozapine. Can you tell any other indications of clozapine? Yes, it is used in refractory schizophrenia. After using two drugs, still if it is not getting result, refractory schizophrenia, and decreases incidence of suicide in schizophrenia patient. Anti-suicidal indication. These two are two main indications of clozapine. indications of closure. Refractory schizophrenia decreases the incidence of suicide. That's all about all the points with the clozapine and olanzapine and little bit about quetiapine also. I hope it is clear for everyone. I hope it is clear for everyone. Is it clear, ma? Nothing much, ma. Not that much. Not that much. Yes, majority of the antipsychotics will be there. Not that much. Not that much. Next, very important point: lithium. Every year, one question will be there. Let's talk about the levels of lithium. Acute mania, how much it should be. All these are milli equivalents per liter. Milli equivalents per liter. 1 to 1.5. Prophylaxis 0.6 to 1. Therapeutic range, we can go for 0.8 to 1.2. Acceptable safe level up to 1.5 is okay. When permanent neurological damage occurs, when it is greater than 3.2, when the hemodialysis needed, if it is 4, if it reaches 4, when the death will occur, if it is greater than 4.2. These are all the levels which was asked once. And when we need to take the lithium levels, it is taken equivalence per liter. It is taken before giving the next dose. Before giving next dose. So today, let's assume to what was the date today? 4th. 4th I have given, and again 4th at 8 a.m. I have given, let's assume one dose. Again 5th, again at 8 a.m. I'll be giving one more dose. So when I need to take the dose, when I need to take the sample. So before giving, at this point I need to take, that is what we call trough level, lowest level. That is what we call trough level concentration. Just remember the name, nothing much. So before giving the next dose, we will take the sample. Next year comes a very important point, lithium ADR. Every year one question will be there from lithium. You can remember all the points with the lithium with the first three letters LIT. So L, leukocytes increased. That's all due to stimulation of colony stimulating factor, due to stimulation of granulocyte colony stimulating factor. I, I is nothing but insipidus. What insipidus? Diabetes insipidus. How do you treat that one? Treated with amiloride. Treated with amiloride. And there is one more I. It may have insulin-like action. So it may lead to little bit of hypoglycemia, nothing much, nothing much. It is not that evident, not evident. 12 hours prior, sir. Not 12 hours prior, just before giving the next dose. Just before giving the next dose. That's it. Just before giving the next dose. When the patient is taking that next dose, then only we have to take. We have to take the lowest level of the concentration. That was a guideline says. That was a guideline says. Just before giving the next dose, that is what we call trough level. And then one more I increased. What increased, sir? Increased weight will be there. Increased calcium will be there due to parathormone. Increased acne, that is worsening of acne, worsening of acne. So these are the eyes. These are the eyes. LIT. Here comes few T's here. Fine tremors is the most common ADR at a therapeutic range. Fine tremors. This is literally the most common at a therapeutic range. At a therapeutic range itself. Fine tremors. And then one more T, thyroid abnormality. Thyroid abnormality. What thyroid abnormality will be there, sir? Hypo, both will be there. Hypo greater than hyper. Hypo greater than hyper. If the patient who is receiving lithium, if they develop a hypothyroidism, do we need to discontinue? Definitely no. Just to give supplementation. Just give supplementation. That is more than enough. Next, teratogenicity. Teratogenicity. That is nothing but Epstein anomaly. Epstein and tricuspid valve defect. Next, we have therapeutic index low. It is having low therapeutic index. And then one more T wave abnormalities. T wave abnormalities. It might be flat or it might be inversed. That's all. That's all about all the points with the lithium. All the points you can remember with the word itself. LIT, LIT. All the points we are covered with the lithium also. Next, here comes Anti-diabetes mellitus drugs, very important, ma. I'll be telling all the pickup lines here. If you see such kind of pickup line, just blindly go for the drug. If you see lactic acid, these all things you might have known. If you see lactic acidosis, then go for metformin. If you see any GIT related areas, especially diarrhea. If you see GIT related areas like predominantly diarrhea, again metformin. Metformin. This was a question you might have seen. This was the recent INICT question. Recent INICT question. Predominantly GAT. If they give diarrhea. Again, there is one more thing also I'll tell. Disulfiram-like reaction. Chloropropamide. And then here comes one more GAT related areas. If they mention bloating, bloating typically, if you see bloating, then it is alpha glucosidase inhibitors, and they are contraindicated in intestinal obstruction as well as gastroparesis, alpha glucosidase inhibitors. Next, indicated in heart failure. This is also one more recent INCT question. SGLT2 inhibitors, SGLT2 inhibitors, contraindicated in heart failure. Pioglitazone, rosiglitazone, all glitazones. Glitazones are contraindicated in heart failure because of water retention. Water retention. Increased risk of fracture. Any anti-diabetes drug with increased risk of fracture, if they mention, then go for this pioglitazone and rosiglitazone. The same drugs, same drugs. Increased risk of UTI. Again, this was the previous year question, as you know. Increased risk of UTI. SGLT2 inhibitors. If they mention something related to pancreatitis, generally don't mention thyroid cancer. Actually, it was seen in animals, but not in humans. But if they mention this pancreatitis and this part, then go for GLP-1 analogs. These are the drugs ending with a glutide. These are the drugs ending with a glutide. Next, if you see nasopharyngitis, or it might be if they mention severe joint pain, then blindly go for DPP4 inhibitors. These are the drugs ending with gliptins. Next, type 2 diabetes mellitus drugs used to decrease the cardiovascular events. SGLT2 inhibitors, typically canagliflozin and empagliflozin. And here comes very important, if they mention decreasing death decreasing death, any type 2 diabetes mellitus drug or anti-diabetes mellitus drug which is going to decrease cardiovascular death, D, dapagliflozin. Remember, if they mention typically death, go for dapagliflozin only. Okay, ma. That's all about all the pickup lines related to anti-diabetes drugs. Very important. See, from this table itself, already we had discussed this table before also. Like in recent INCT, this was the question, this was the question, this was the question. Three questions came from just from only this table. Already I had discussed all these parts. I think in the previous high yielding session, I think so, or it might be VSV. I didn't remember actually when I have discussed. So that's all about anti-diabetes mellitus drug. And here comes a very important one, antifungal agents. Every year, one question will be there from antifungal mark. Every year. Mostly you'll be asking mechanism of action or drug effects. Only those two. So in a fungal cell, is there anything which is going to inhibit the DNA RNA synthesis? That is flu cytosine. Flu cytosine. It is going to inhibit DNA RNA synthesis. Flu cytosine. Okay. There is something which is going to bind to ergosterol and make pores. Amphotericin B nystatin. They make pores. They bind to this ergosterol component and they make holes so that everything will be more permeable and cell will die. And there is something which is inhibits a beta glucan synthase enzyme, echinocandins. They inhibit the beta glucan synthase. And here comes main important thing, azoles. So we all know squalene converts to squalene epoxide. That step is inhibited by squalene epoxide synthase. That step is inhibited by terbinafine. And it converts to lanosterol and converts to ergosterol, the component in cell wall. This lanosterol and ergosterol component is inhibited by azoles. Nothing much, nothing much. These are all the basic things which you already know. SGLT2 inhibitors cause fracture. No, ma, no. No, they don't cause fracture. They don't cause fracture. Only pioglitazone, rosiglitazone are involved with fractures. Involved with the fractures. SGLT inhibitors means it might be the non-specific one. Just blindly go for UTI. That's it. That is a main characteristic area with SGLT inhibitors. So now coming to drug of choices, ma drug of choices. Aspergillosis, the first one, aspergillosis. Yes, you got this question regarding aspergillosis. Not aspergillosis. He asked about voriconazole in recent INICT. No need to worry. That those questions, even MD postgraduates, even assistant professors, associates, also that will be very difficult for them to answer because those are like typical statement kind of questions. No need to worry if, even if you cannot answer such a bouncer questions. They won't expect you people to answer them. They are just for a filling sake. They are just for a time being filling sake. Invasive aspergillosis, oriconazole, oriconazole. But if they mention fungal asthma related to something related to aspergillosis, then it is itraconazole. This conazole I'll be writing with a C ma, so just for time being sake, I'll write C, that means itraconazole. Blastomycosis, 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 immunocompetent patients, immunosuppressed patients. Immunosuppressed patients, go for amphotericin B, go for amphotericin B. In immunocompetent patient, it is itraconazole. If it is mild to moderate, in severe, go for amphotericin B. In severe cases, go for amphotericin B. Amphotericin B. Here comes candidiasis. This was asked like 4 to 5 times, 4 to 5 times, 4 to 5 times. Oral trust. It is clotrimazole. Clotrimazole. Majority of the people will get confused. Nystatin. Nystatin, it is an alternative one. First line drug will be clotrimazole only. Nystatin is an alternative one. Vulvovaginal candidiasis or esophageal candidiasis, anything, fluconazole, fluconazole. Prevention in neutropenic patients. In neutropenic patients, hospitalized patients, candida infections are most common. If you want to prevent, what you can use? Posaconazole, posaconazole. In disseminated candida infections, most commonly used drug is fluconazole. But first line of drug is echinocandins. Remember, a very important, most commonly used fluconazole, but first line drug is echinocandins. Echinocandins. Here comes one more thing: Candida meningitis. Candida meningitis or Candida endophthalmitis. Candida meningitis, Candida endophthalmitis. We give IV amphotericin B along with flucytosine. Flucytosine. Next, typical things, Candida albicans. Candida albicans is more sensitive to fluconazole. More sensitive to fluconazole. These kind of like typical high-end questions because this Candida is the most important one. Sir, need previous slide. Yasma, Shiva, Rubhani. I'll show these things. I'll show in the last. Definitely I'll show because if we keep on going through these things, we'll be missing the time. Already, it's only the 10 minutes is left. I will show you my last. I'll show all the notes. All the notes. I will share these notes also to you if you want. Definitely. Okay, ma. Shiva Rubini. So, with the most important thing, we need to go bit in detail. So, Candida glabrata, Candida cruzi, and Candida auris. If we give these three, what you call Candida species, except albicans, just to go for first line drug is echinocandins. Because these three are least sensitive to, they are less sensitive to fluconazole. They are less sensitive to fluconazole. So, echinocandins. Even with echinocandins, if they are not getting treated, go for amphotericin B. Only with only with these three. Chances are there to ask. Chances are there to ask. Coccidioidomycosis. Coccidioidomycosis, if they give pneumonia, go for amphotericin B. If they give bone and joint infections, then go for itraconazole. If they give meningitis, go for fluconazole, followed by amphotericin B. Amphotericin B. In a pregnancy situation, we all know azoles are contraindicated in pregnancy, so blindly we'll go for amphotericin B only because all the azoles, itraconazole, fluconazole, all are contraindicated in pregnancy. So in any pregnancy, whatever it might be pneumonia, bone and joint, meningitis, whatever it might be, we blindly go for amphotericin B. Next, paracoccidioidomycosis. In the acute condition, we go for amphotericin B. Amphotericin B. In a chronic condition, we go for itraconazole. Next, histoplasmosis, whether it might be acute or whether it might be CNS, whether it might be disseminated, anything, whatever it might be, amphotericin B, amphotericin B, followed by itraconazole. Here, chronic lesions, blindly go for itraconazole. Simple ma, paracoccidioidomycosis, histoplasmosis, same. Acute chronic, treatment is same. Amphotericin B, itraconazole. Both are same, nothing to worry. And here comes, this was the question which was asked. This was the question which was asked. Two times it was asked. Why there is anadula? Echinocandin, ma, that one. Echinocandin. We can use it for all patients except children. Except children. Anidula fungi. Anidula, we can use it for everyone except children. We can use it for everyone except children. For children, it is not approved. This is the only echinocandin which was not approved in children. Anidula. Except children, we can use it for everyone. Except children, we can use it for everyone. We can use it for immune compromise also. Everyone we can use. Dermatophytes. Again, people will get confused here. Terbinafine is the first option. Next, itraconazole. Mucormycosis, go for amphotericin B. Sporotrichosis, sporotrichosis. Sporotrichosis, first line drug will be itraconazole. If there is CNS infection, then we go for amphotericin B. Amphotericin B. Amphotericin B. Sporotrichosis, this was the question which was asked. Sporotrichosis, itraconazole. This was the question which was asked. Next, very important, cryptococcosis. Very important, cryptococcosis. Without just two simple things, ma. Cryptococcosis, I divided into two categories: without CNS involvement, with a CNS involvement. Without CNS involvement, it might be anything, pulmonary, extrapulmonary, whatever it might be, whether he is HIV positive, HIV negative, whatever it might be. Cryptococcosis, drug of choice is fluconazole. But CNS involvement it is there, but a patient is HIV negative patient. HIV negative patient, then we can use amphotericin B. If he is immune competent, if he is immune suppressed, then we can use amphotericin B followed by fluconazole. Fluconazole. Immune competent, immune suppressed. But if he is HIV positive, then use amphotericin B plus flucytosine, flucytosine followed by fluconazole. Fluconazole. This is what a cryptococcosis treatment protocols. All like every year, one question will be there from fungal infections. Like predominantly, he'll be asking either cryptococcosis or candida, dermatophytes, sporo. This was the question which was rotating under the same headings. That's all about antifungal agents. Now let's talk about characteristic ADRs with amphotericin. Antifungal agents. Amphotericin B infusion-related reactions. It is most commonly seen with amphotericin B colloidal dispersion. We call it as ABCD, amphotericin B colloidal dispersion. Most common infusion-related reactions are seen. Is it posaconazole greater than isavuconazole? No, ma. Mucormycosis, amphotericin B. It is seen by Harrison. Mucormycosis. Okay, na? Those are alternatives, ma. First thing will be amphotericin B, other are alternatives. Nephrotoxicity and bone marrow suppression. If an antifungal agent, nephrotoxicity, bone marrow suppression, go for most common with ABCD, amphotericin B colloidal dispersion, least common with lipid amphotericin B, that was liposomal amphotericin B. So what are the characteristic area with flucytosine? Bone marrow suppression will be there, and severe colitis will be there. Voriconazole, V, vision abnormalities. Itraconazole, it has heart failure, and then it is going to decrease potassium. These are the two characteristic areas, black box warnings for itraconazole. Because for majority of the drugs, drug of choice is ABCD. ABCD means amphotericin B colloidal dispersion. Amphotericin B colloidal dispersion. ABCD. Amphotericin B colloidal dispersion. So because itraconazole is the most commonly used one, so that is the reason why they have given black box warnings for a long period of time. Because all the antifungal agent we need to use for long period. So heart failure and decreased potassium levels. That's all about entire antifungal agents, ma'am. Entire antifungal agent. Last 5 minutes we have. Yeah, last 2 or 3 slides. We'll finish by. Ma, it's okay now. Or if I continue for the next 5 or 6 minutes, is it okay for everyone? If you can reply, that will be yes, yes. Okay, ma. Thank you. So here comes again from this, from trust me, from this page, only from this page, you will get one question, ma. You will get, every year he's giving one question only from say the cell wall synthesis and protein synthesis. Thank you, Maharish. Thank you. So every year one question will be there. So cell wall synthesis inhibitors. Cell wall synthesis inhibitor. These are all the agents. These are all the agents. You all know penicillin, cephalosporin, carbapenem, monobactam, cycloserine, all these. But that's not he. This is not he is not doing. He will not ask these kind of things. He will ask you what steps are inhibited by this thing. What steps? All cell wall synthesis inhibitors are bactericidal. Remember, cell wall C. All are sidals, except one, which is cycloserine, which is bacteriostatic. This is bacteriostatic. Remaining all are bactericidal. Everyone will kill. Every drug will kill. Bactericidal. This is only bacteriostatic. This is one first point. Okay. So the first four, they all inhibit peptidoglycan cross-linking. This step is inhibited by penicillin, cephalosporin, carbapenem, monobactam. So this step is inhibited by these four, peptidoglycan cross-linking. So we have one more two things, whereas literally peptidoglycan synthesis is inhibited. Glycopeptide bacitracin, they inhibit the peptidoglycan synthesis. They inhibit the peptidoglycan synthesis itself, literally synthesis. And these peptidoglycan, and we have something known as alanine residue. Two alanine residues will come and will join. It is going to form what you call strong bond. This cycloserine, it is going to inhibit attachment of alanine residues. Inhibits attachment of alanine residues. That's all about bacteria cell wall synthesis inhibitors. Peptidoglycan cross-linking and peptidoglycan synthesis, which inhibits the alanine residues, cycloserine. That's all. And then coming to protein synthesis inhibitors. These protein synthesis inhibitors, you can remember with a mnemonic at 30 for CM, we lost our CM. At 30, CM lost. At 30, CM lost. So at CM LOST. Aminoglycosides, tetracycline, chloramphenicol, macrolides, lacosamide, oxazolidinones, streptogranins. What is this at 30? So these, so this at 30, these two going to bind with the 30th ribosome at 30, and all the other bind with the 50th ribosome. That is what at 30. Okay. And then which is bactericidal, which is bacteriostatic, sir? First one is bactericidal, aminoglycoside kills. Streptogranin is the last one, bactericidal kills. Remaining all are bacteriostatic. So at 30 cm lost. All are 30. These two are 30. Remaining all are 50. First one, last one are bactericidal. Remaining all are bacteria static. I hope every year one question will be there from this page. Every year one question will be there from this page. And here comes one more thing. Yeah, last two slides, ma. Last two slides. Again, a very important one. Concentration dependent killing and time dependent killing. These are like I think two or three questions were there previously in the last 4 years. So concentration dependent killing, all fluoroquinolones, aminoglycosides, metronidazole. You can remember with the mnemonic, first three letters, family. When we were with the family, our words will be very much concentrated. We will be very much concentrated while talking. We cannot talk whatever we want to talk. We'll be much more concentrated. Like with the friends, we'll be talking. No filter will be there for our mouth when we are with the friends. But with the family, we should be very much concentrated while we are talking. So family, concentration dependent killing, concentration dependent killing. Next. So next, time dependent killing. Time dependent killing. All the glycopeptides, licosamide, linezolid, beta lactams, and macrolides. How to remember this one, sir? So glamour. Girls will take more time. Girls will take more time dependent. It is time dependent killing. Girls will take more time to look glamorous because they need more time for makeup, all such kind of stuff. So glamour, glycopeptides, lacosamide, L, linezolid, again LA, lactams, beta lactams, M, macrolides, glamour. They take more time dependent killing. The girls, they take more time to look glamorous so that they can kill the boys with their looks, with their thing. And family, if you're not that concentrated when you're speaking with the family, they are going to kill you. You should be very much concentrated, otherwise, they will kill you. So that's all about concentration dependent killing and time dependent killing examples. Next, here comes a one more thing, post antibiotic effect. It is seen with simple, nothing much. All concentrated dependent killing drugs, that is family drugs, with rifampicin. These are the drugs which having post antibiotic effect. Post antibiotic effect. Next, very important, carbapenems. Carbapenem, the drug causing seizure is imipenem. Imipenem. Oral carba, all are IV except one, that is oral carbapenem, pharopenem. So this imipenem we use cilastatin. Cilastatin. Which is going to inhibit the renal dihydropeptidase. Which inhibit the renal dihydropeptidase. 1 second, please. Which is inhibit the renal dihydropeptidase. Cilastatin. Cilastatin. Here comes one more thing, pseudomembrane colitis treatment protocol. So, like once in maybe 3 or 4 days, definitely I'll get a message from a student regarding pseudomembrane colitis protocol. Those are having bit confusion, like clear-cut guidelines. These are primary pseudomembrane colitis. If it is primary pseudomembrane colitis, which one we use? First line of drugs, oral vancomycin or fidaxomicin. Fidaxomicin. This is a first line drug. First line drug. Alternative is metronidazole. Metronidazole. When oral vancomycin, fidaxomicin is not available, then only we'll use metronidazole. Recurrence. If it is first time recurrence, go for fidaxomicin greater than vancomycin. If it is multiple times greater than first time, go for vancomycin. Go for vancomycin. If it is fulminant, very dangerous, oral vancomycin plus IV metronidazole. That's all about all the guidelines of pseudomembrane colitis. I hope I made it clear here. Pseudomembrane colitis, primary recurrence, first time recurrence, multiple recurrence, fulminant. All the guidelines of pseudomembrane colitis. Last 3 or 4 minutes, I'll finish this anti-tubercular drugs and we'll wind up the session. Every year, one question will be there from anti-tubercular drugs. One question definitely from this box. Trust me. So we have these drugs: isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Streptomycin typically not a first-line drug. It is a supplemental first-line drug. It is a supplemental first-line drug. It is a supplemental first-line drug. Okay, sir. What is the route of administration? All are oral, except this one. This is parenteral. Because it is aminoglycoside. All aminoglycoside we give parenterally. Whether which one is bactericidal, which one is bacteriostatic, sir. So all are bactericidal except one. All are bactericidal except one, ethambutol. See, students get confused here. Ethambutol. Boys, they'll watch girls back, and they will stop static, right? Remember this one? Static. Clear? Next. Where they will act, sir? Whether they will act intracellular, extracellular, both, both, both. This ethambutol is also both. Pyrazinamide acting intracellularly, streptomycin acting extracellularly. Streptomycin is acting extracellularly. Which again, I think this was the question which was asked, I think like 3 or 4 years back. Pyrazinamide, it's like Piari, Piari. Piari means love. Piari means love. So love, we should love from inner side. It's not just like outside looks, nothing much. That's we call it as a lust. Piari, you should love from inner, intracellular. Got it? That's all about this part. And then coming to mechanism of action, here where examiner tries to concentrate more. It is going to inhibit mycolic acid synthesis. It is going to inhibit mycolic acid synthesis. Rifampicin, it is going to inhibit DNA dependent RNA polymerase. This was the question which was asked. And the pyrazinamide also inhibit mycolic acid synthesis. Ethambutol, it inhibits arabinosyl transferase. Again, this is also the question which was asked. Streptomycin, as you already know, 30S ribosome. 30S ribosome, inhibit that bind to 30S ribosome. That's all the stuff. Next, here comes resistance. Again, this is one more question which was asked. So, how the rifampicin is produced? Isoniazid is getting resistance because of CAT-G mutation. CAT-G gene mutation. Rifampicin, RPO mutation. RPO, rifampicin, RNA-dependent polymerase. RNA polymerase, simple, nothing much. Pyrazinamide, the name start this mutation gene start with a P only. PNCM mutation or PAN-D mutation. PAN-D mutation starting with a P only. Ethambutol mutation starting with a E only. EMB mutation. EMB mutation. And streptomycin, RRS mutation or RPS mutation. Nothing much. Nothing much. These things you can what do you call this rifampicin P. These three are very easy. So CAT-G and RPS, something related to R, you need to remember. Again, here comes the most important thing: hepatotoxicity. Which drugs are hepatotoxic? First three are hepatotoxic. Last two are not hepatotoxic. Very important. Coming to characteristic areas, hepatotoxicity is there. Peripheral neuropathy with isoniazid. That's why we give vitamin B6. And then rifampicin, red orange urine characteristic area. Pyrazinamide, it has photosensitivity, and it increases the uric acid levels. And ethambutol, it also increases the uric acid levels, and it is associated with retrobulbar neuritis. And then streptomycin, you all know, nephrotoxicity, Ototoxicity. That's all about antitubercular drugs. That's all. That's all about this session. It's almost like till 7:40 we have covered. I think we started at 6:05. Almost 95 minutes roughly. So that's all about the entire session. So I forgot to introduce myself. I'm very sorry for a late introduction. Myself, Sudheer Prudvi, or anything for these notes or any doubts related to pharmacology, contact to this number. I'm always there to help you people. Or you can just text me the same thing, the same name to Instagram, Sudhir Prudvi. Should definitely, ma, definitely I'll share. Definitely I'll share. Just text me. Just text me to this number. Definitely I'll share this video. Oh, definitely my show. So the same thing, ma. So Instagram also they have the same name and just text me. WhatsApp, concentration dependent, time dependent killing. Yeah. No, so definitely, ma. Definitely I'll share. Definitely I'll share. I hope this session is useful for you. All the major important things I have covered. Please go through these things in the last moment. Last moment. Thank you, ma. Thank you so much. Thank you so much. Thank you, ma. Thank you, ma. Thank you so much. Thank you so much. Still, any no, any such kind of things? I'll antifungal definitely, ma. Definitely, so antifungal. Thank you so much, ma. Thank you all. Thank you all. Please concentrate. Please read. Don't leave all the next coming some 17 days or something like that. Don't give up. Just keep on reading. Keep on reading. Don't do any other stuff. Just keep on reading. Concentrate more on previous year MCQs, previous year topics. Keep on revising them. Revision is the only key. Revision is the only key. Revision is the only key. There is no hard work. There is no shortcuts for success other than hard work, ma. Thank you, Magiri. Thank you. Just keep on revising the things. Remember, you didn't come this far to only come this far. You have done a wonderful work, so much of hard work, so many sleepless nights in the last 1 year. They are going to pay off uh, in meanwhile. So just keep on reading, keep on reading. No, ma dermatophytes terbinafine. Clearly, Harrison says it is terbinafine. Clearly, Harrison says it is terbinafine. Dermatophytes. Second option is itraconazole. Second option is itraconazole. Ma. Clearly, Harrison says it is. That's what I told. Majority of the people will get confused there. Clearly, Harrison says it is terbinafine. Thank you so much, ma. Thank you all. Fresh up, have breakfast, start reading. So, thank you, ma. Thank you so much, ma. Thank you so much, Santosh. Thank you so much. Thank you, Karthik. Thank you. So, this PDF, I think they'll upload in the app also. I think so. But definitely, I'll share to you people also. But I think they'll upload in app also. You can go through that. So that's all, ma. Can we leave? Which app? ADRPLEXUS app, ma. Yeah, Plexus app only, ma. I'm not sure like which app it is, like related to ADRPLEXUS only, but I don't know the name of the app. Rhythm or the original. Okay, fine. I don't know the exactly. You please check both, ma. I don't know. You please check slow all slides. I will share the notes to you, ma. Monica. All slides once. It's a very difficult actually. I'll share you the notes. I'll share you. I'll share this to you. Just text me with your name. I'll share the notes. It will be very difficult to show all the slides now because time being, it's almost like 25 slides are there. Okay, then. Bye bye. All the very best. All the very best. Keep reading. Keep revising. Don't get distracted. Just keep on doing the things. Keep on doing the things.